Hey, could someone please call Respiratory?
Welcome to the Hey, Could Someone Please Call Respiratory podcast with your hosts Eric Harder and Denise Van Baal.
All right, so we are back today with another episode of I screw it up every time I say it. Hey, can someone please call Respiratory podcast, which is a podcast that we're having. You may notice a very handsome looking gentleman. It's actually Brad Pitt's brother, Larry, is on the podcast with us today. Yeah. And he is his name is Tom Lamphere. He is the executive director of the Pennsylvania Society for Respiratory Care. And in fact, many years ago, this is a silly statement, but Tom, I emailed you from Southern California in like 1999.
Yep.
And I said, I'm thinking about moving to Philadelphia. Are there jobs out there? Whatever. You sent back an email, and gave me all this information, whatever. And then in later years, I contacted you about this type of business that we do. And so really through the years, I've harassed you is what I'm getting to.
You're good at that.
Yeah. I'm real persistent that way. And then I even I asked you to come to a sales meeting one time. And I think I introduced you as the Ryan Howard of Respiratory.
Does that ring a bell? Like told me that. Yeah. Except now people don't know who Ryan Howard is anymore. You know?
Yeah. Well,
that's how much time has passed.
Yeah. You are still the Ryan Howard of Respiratory in my eyes.
Don't think so. Maybe in your eyes.
Yeah. So I appreciate you being on the podcast. As always, we have Denise Van Respiratory up in the left-hand corner. And she is the director of operations at our company, making sure all the I's are dotted and T's are crossed. As I was telling Tom on the podcast, she's actually the best respiratory therapist I've ever worked with. That's no lie. And it's kind of what we're going to talk about a little bit today. I think, Tom, pick your brain on is basically increasing your value as a respiratory therapist or the future of respiratory care. And so what stuck out with Denise, besides her telling me when I interviewed her that she was pregnant, right? And that basically she just really needed a job. And what else? Am I leaving anything out?
I love old people.
Yeah. And so, but she was, she wanted the job. And anytime, I've, through these years of interviewing people and hiring people and all, I like when somebody seems like they like the job or they are interested in the job, and I don't know. It seems like there's so many times where you interview somebody and it's like you're bothering them, like, what are you even here for? Like, you got this.
I've been a manager, 2 different hospitals, 2 different times. And that's like one of my biggest pet peeves is somebody walks in and you can tell within 30 seconds that they really don't care. No. They don't come dressed up. No, I don't think you need to wear a suit and tie, but I've seen girls come in with crop tops on, guys come in with flip-flops on. It's like you're going to an interview for a job. You think you have some idea what you're doing. And then even beyond that, because I've had some people that you kind of look at and you would say, all right, and maybe they don't dress the best, but you could tell when you talk to them that and the key word I think you're missing and what you were trying to say is you want somebody with passion.
Yeah.
That they have a passion for what they do. I mean, and I know, you and I have been doing this a long time. I've been doing this 30 years. I'm probably as passionate now as I was then, maybe even more so, just different.
Yeah.
And you're the same way. You started out in the hospital and, your passion took you out of the hospital into other areas, but it's still, we don't do this because we're going to become millionaires. Denise, are you a millionaire?
Yes.
Okay. Thanks.
I have a boat. I'm not a millionaire, but I do own a boat.
Yeah. Okay, she has a boat.
There you go. All right.
Northeast Philly.
We do this. We make decent money, right? But it's not like we're doing this to retire early. So if you don't like this, why are you doing it?
Yeah.
And there's a lot of therapists out there and a lot of nurses, a lot of doctors that I sit there and I go, why are you doing this?
Yeah. Yeah. So that's a good point. I think also just lie to me. Like act like you're really interested in the job and like, oh, this is amazing, whatever. And then you can always follow up and say, well,
make it till you make it. I don't care if you hate your job when you're in the hospital or you're doing whatever you're doing, smile, make everybody think you love it. Inside, you might hate it, but that's okay.
Yeah. So that kind of leads me into, I anytime I get around you, and again, my harassing you through the years, because that's my gift is what is the future in your eyes of respiratory care? Like, how do you feel about where we're going as an industry?
I think it's my opinion has changed slightly over the years, but it's always been the same thing. And that is, our field started and our profession started, from a need of equipment people. People that understand the equipment. And this is back in the days where the equipment was kind of, we laugh at it now, the MA1s of the world and that kind of thing. And the equipment was sophisticated for the times, but that's changed, dramatically. Look in the last 10 years, what's changed dramatically. So it's still equipment based, but to me, you can teach, especially at this point, if you have a teenage kid, they can probably run the ventilator better than you can. Because they've grown up with iPads and iPhones and all that, so they've grown up equipment. Right. So I think our profession is changed dramatically that way, but and that's I think affecting where we're going in the future. A lot of what we've done in back in the 60s and the 70s was pushing oxygen tanks around, putting in IPPB machines and things like that. That's all gone. For the most part now that the equipment's gotten smarter. We have ventilators now that you can basically just turn on and, there's a couple of modes that you just have one button to push. Yeah. You need someone that really knows the physiology. I would say yes, but beyond the ICU, that's where I think things are starting to fall apart, where you don't need somebody to give breathing treatments. And you and I have talked about this in the past. Does every breathing treatment have to be given by a respiratory therapist or even a nurse necessarily? No. I think one time you told me you could have a monkey come in and do your MDIs for you. And I said, yeah, I kind of agree with you. A smart monkey would be nice because they could at least show it correctly. But I think our profession is heading towards a time where there's going to be a big reduction in the number of therapists. But what's going to be left are going to be really good people. They're going to be the best of the best, the cream of the crop. And I've been teaching for 15, 20 years now. And I tell students that every year. I'm like, look, you don't want to be the person that's, all they care about is how much do I make and how little can I do? But, how can I help my patient? We teach them all this information. And I always tell them one thing. If there was one thing that worked for every single person, we'd all do it, right? If there was one mode of ventilation, if oxygen worked for everybody, or if there was one medication, everybody would be on that, but it's not that way. So we get this toolbox, and I think what our profession should be and what every therapist should be is the person that knows what tools are used in that toolbox for what patients. It's not one size fits everyone. Right now, the way it's set up in healthcare is, one size fits everybody. And that we know that's not correct. And that's why we have, unnecessary treatments, and we have, therapies that are useless on some people, but should be on other people that aren't getting it. And I think that's where we can grow as a profession rather than doing the same old thing we've been doing.
I think it's interesting. Like, I agree completely with what you're talking about. And I've always been interested in like growing things and business, of course. And so I don't know that I would have been, involved in respiratory this long if I didn't have the opportunity to kind of start and grow my own thing. Right. So that's kind of what and it's awesome. And I tell everybody that we work with even on your worst day, you're helping people breathe, so even on a bad day, you're helping people, and that's pretty great thing. And you should be proud of that. So, however, working in the first 2 years, I really love, oh man, this is awesome. You wear a lab, I started out in Southern California, wear a lab coat, scrubs, and you go, all these amazing things that are happening and whatever. And then after a while, I started to see kind of, I was in my early 20s and I started to see the people that were 20 and 30 and 40 years my senior, and just looking like they dragged in the dog, when they came to work, and they were just like, oh yeah, this is terrible. And I'd be like, what are you guys talking? I was confused. And so, but some of these hospitals, they just hand you a list of neb treatments and a beeper for the ER. And so doing that over and over and over again, I really saw kind of the future in my eyes of like, how can this sustain itself? God forbid, and I don't want to irritate anybody, but I'm pretty good at it, so might as well, is that if I'm the CEO of the hospital and predominantly respiratory therapists are giving nebulizer treatments, I'm having LPNs do that. I really am. And there's no department anymore where you sit in the department. I'm putting you in the unit and in the ER, and maybe, PACU and some of these places where you're weaning people off the vent, you're right there with the nurse practitioner or the doc, whatever it is, helping to rotate the ET tube and guide and direct and try new things and draw the blood gas and make the changes and all that stuff where you're part of the group. And even in later years, I was a traveler, and I traveled, different locations. And I took a travel assignment in the early 2000s at a pediatric hospital, and in the ER, they were trying some new thing. Right. And so they didn't even really know what they wanted a respiratory therapist to do, but they were in such dire need for nurses that they're like, let's just have somebody come in, whoever. So
it's funny. When I was a manager one of the times, and again, multiple places, but at one of the locations that I worked at, in fact, both, and another place where I actually worked, I wasn't a manager or a supervisor, but I was just working here. One of the programs that I wanted to start, and actually did start in one place, was we would have a therapist get called to the emergency room, and instead of, come down and do this treatment, it was come down and evaluate this patient. So the protocol, and God forbid you say protocol in our industry, but the protocol at that time was if a patient came in with hypoxemia or any kind of signs of respiratory distress, they just paged respiratory. And then we went down, and what did we do? We evaluated. We did spirometry. Spirometry in the ER. People thought I was like, you think I was the devil incarnate because I said we should do spirometry in ER. Not peak flow, which is a complete waste of time. But, I have people that think I'm crazy because of that. Well, I've worked with Bruce Tobin, who was one of the top people in respiratory for years and years. And Bruce was the smartest guy I think I ever met. And he said, what's peak flow? And it was at Germantown Hospital. And he said, we don't even carry them here. And I said, what do you mean? And I was just out of school. I'm like, what do you mean? We don't have peak flow? We just learned about it. He said, they're useless in the hospital. They're great for at home where a patient can get a baseline level. He said, but it's useless in the ER. You go in and the doctor says, do a peak flow. Patient does a peak flow. And you come back and say, doctor, the patient's number was 250. And the doctor says, what's that mean? And he says, well, that's pretty good. I'm like, what if I told you his normal was 500? Oh, well, then that's not very good. Well, what if his normal is 250? Oh, then it's excellent. So it's a useless number, right? So we would do spirometry, and we would go in and we would make, recommendations, and then we could actually do the first treatment if they needed the treatment. That protocol lasted about 6 months, and then it went away. And you don't want to know why it went away? Because the therapists that I was working with, the majority of them hated doing it. They hated getting called to the ER to evaluate a patient. There were a group, and Denise, the group I'm talking about, who loved it. It was awesome. It was like, wait, I can go down and use my brain and use my knowledge and use the equipment that's appropriate and make recommendations to a doc. So those people, when they were down there, the docs loved it, because if I went down and I did an evaluation, I go to the doc and say, this is what they need. They would do it. But then other therapists would go down and they would do as little as possible. And they would, what's a good word for saying piss and moan? They would piss and moan about it the whole time,
Right.
And ultimately it derailed the entire process.
Yeah. Yeah.
So
and
that's what I think has to change. Medicine is moving more towards that protocolized, they don't need us to do all the, call it scut work, if you will. Right. And I think the problem is, back when you and I went to school and we got out, and even before us, what was a therapist? It was very much a do tasks. It was task oriented for everything. And now that's completely changing. And if the new kids coming out of school are smart, they know their stuff, but we're moving them away from task oriented and using, talk with the docs, talk with the nurses, become part of the team. And I think for the people that have been around a little bit longer, that idea of team, they don't like that idea.
Right. Yeah. In that ER, I remember being down there and they're like, kind of like, well, I guess go listen to everybody's lungs. And I was just like scratching my head. I'm like, I'm going to be down here for 12 hours. Like I got to do something else, like, and I, one of my things is be the change you want to see in the world. Right. So I was like, and trust me, no God's gift to respiratory care, that's for sure. But I also wanted my time to be effective. And I also wanted to like not look at the clock for 12 hours and wait and do a breathing treatment every 2 hours. So I was like taking people to CAT scan and, holding for sutures and
IVs in. I did that for a while.
I didn't do they didn't let me do that.
You draw the line at
IVs, EKGs.
But yeah, that's something that, right, that they should let them do. And if you create that value, right. And so that's really the main thing, create value there. And if we're not creating value and becoming linchpins in the facility for these organizations, then really what are you doing? We could pay anybody to do that stuff. And I kind of through the years kind of tried to, and I felt like I saw that writing on the wall and just was like, and then, we're serving, fast forward years later, where we started servicing nursing facilities and hospice organizations. And certainly within the nursing facilities, like predominantly a lot of the medical equipment companies are just having drivers drop off devices and the nurses have no idea high flow.
Now you've got high-end equipment and it's becoming more and more higher-end equipment. It's like buying a Porsche to drive around to the Wawa around the corner, and that's all you ever drive it.
Right.
Because you don't know what it can do, and you don't, why would you spend all that kind of money on it? Yet home care companies, they've upped their ante in terms of equipment, but the nursing homes and those types of facilities, subacutes and so forth, they're not utilizing it correctly. They never do, because they don't have the right people there that even know how that equipment works.
Right.
And is that, that trilogy unit, is that really what's appropriate for that patient? Maybe it's the guy 2 doors down who really needs it. And he's sitting there with a 30-year-old CPAP machine. Yeah.
And so we've always tried to, be ahead of that curve and create that value. And especially now, right, Denise, like with PDPM and the nursing homes, how's that working?
They have to take a higher acuity patient to make money now. They need that trach patient. They need those acute cardiopulmonary patients. And they need a respiratory therapist in the facility to help guide their care. Because if they don't have that, then that patient's just going to end up going right back to the hospital. And the therapists in the building, they aren't running and giving breathing treatments. They are making sure that if the patient is on a trilogy, that it is appropriate for them. And they are making sure that if the guy down the hall isn't on anything, or he's on this 30-year-old CPAP, that maybe something else might work for him. And they're making those recommendations, and they're building relationships with those doctors and nurse practitioners and really unloading their value into those facilities. Being a therapist, doing what they went to school for.
It's amazing how that goes away. People forget what they actually go to school for, and they settle for just doing things. One of my favorite things that I ever remember is walking into an ICU one time and having a nurse look at me and say, "Oh, thank God you're here." And it was one of the most rewarding things and one of the most telling things all at the same time. Because I thought, well, that's great. They're really happy I'm here today. And it was a busy as hell day. We had like 10 ventilators and they were all bad, and it's like, okay, well, they're happy to see me. But it was also an indictment, because they're like, if you're not here, and so-and-so's here, I know it's gonna be a crappy day. And that's a lot of what's out there. So I think it's important that, the therapists that are out there, and I know, Eric, these are the people for years you've been telling me, I want somebody that likes what they do. I like somebody that actually knows what they're doing. Yes, that's number one. But number two, and maybe even 1A, is that they enjoy this and that they want to use their brains. They don't want to just go in and do what you were saying, walk into the ER and say, what am I going to do now? Oh, I just go do a treatment, and then I go sit on my butt for 2 hours and wait for the next treatment to come in. And that's an indictment. And I don't think that's just respiratory. I think that's every profession. And,
agreed.
Is no different. But that's what we need. We need the people that are really good, that really enjoy what they're doing and utilize all the tools and knowledge People like to forget learning as soon as they get out of school. They don't want to learn again.
Right.
How many people love going to continuing education courses? Oh my God. It's like pulling teeth, right?
Right.
Yet if they actually utilized it and went to good courses, they could learn more. There's so many therapists I know that don't even know what ventilator graphics are, or even in your area, what the different BiPAP machines are and how they work. And ask somebody what a rise time is.
I just watched I just did the CEUs, and I bought a bundle that was specific to all the things that we do in the nursing home. And I did watch all of them, like, all the new machines out for sleep disorders and tracheostomies and all of that. And it's really a lot of good information.
And you sit there going, wow, I didn't know that. And I'm supposed to be the expert. So that's when you realize that. Think about that. If we don't know it, nurses don't know it.
Right.
Docs don't know it. God, docs don't know it at all. I've seen docs order the same settings for 10 patients all on the same trilogy unit. Really? Every patient's exactly the same? Okay.
Sure.
We all have
Tom,
stories.
Thinking about like your experience predominantly in hospitals and being a manager, and having those frequent what they call them, frequent flyers in and out of the hospital, going to the nursing home, coming back, going to the nursing home, coming back, coming to the nursing home, coming back. From the hospital's perspective, like how irritating is that? And that's part A. And then part B, do you then in your local hospital know the nursing homes that differentiate themselves from the other ones?
So it's changed over the years a little bit. It used to be, hey, send them to us, we would make money. And,
right.
It was the same thing. The more treatments you gave, the more money the hospital made. We were the kings, respiratory were the kings of income, right? We were viewed as a profit making, and we were the number one profit making department in the hospital. And then that all changed in the 80s and 90s, and we suddenly became, when DRGs came into play, we became the biggest expense in the hospitals. And so then I kind of look at it the same way for admissions. Patients would come into the hospital and it'd be, yeah, that's great. Now it's the last thing you want is the patient to come in. You do need them to come in, obviously, but you need them to come in and get them out.
Right.
And so it's funny. I teach our students now, the first thing, day number one, they've never met me before. They come in to school, and before whatever class they have with me for the first time, the first thing I tell them is, here's what you need to know about respiratory therapy. What's your job? What do we do? And do we make money for hospitals? And they're all like, I don't know, because they're all students. They know nothing. And I'm like, here's the thing. You can do 1 million treatments and not save the hospital any money. In fact, you're costing the hospital money. The key is to get your patients better faster. And they look at me like, well, why is that? I'm like, because hospitals only make money when you can get the patient better and get them out, because they get a finite amount of money. And if they're discharged, and the patient's still sick and come back, they're not going to get reimbursed for that the way the rules are now. So It's become a huge deal. And I can't tell you how many people don't even realize that. And to me, nursing homes, they are in the same boat. And you know this better than I do. But they don't want their patients leaving, and they lose money. And that may not be as much money as it once was, but it's still money. So I think both hospitals and nursing homes and subacutes and so forth, they're in the same boat. They don't want the patient in the hospital. If they have to go, sure, that's one thing. But the better job we can do taking care of them there, and even home care is the same category.
Yeah.
Everything in this country is moving towards out of the hospital care.
Yeah.
So to me, a nursing home, and how many years did you and I talk that there were no respiratory therapists in a lot of these nursing homes?
Right.
And the ones that did have them didn't utilize them correctly. They just had them doing treatments, but they weren't evaluating anything or making sure the patients were getting the appropriate care.
Yeah.
So is there a difference? Yes, absolutely.
Yeah.
There are nursing homes that get it and have the right staff and are utilizing the right equipment. And there are those that are just collecting a paycheck.
Right. Yeah. I mean, in the nursing homes, like the COPD patient, they give them 14 days and they want them rehabbed and cared for within 14 days. And so that patient specifically, and as they had the previous PDPM is that patient-driven payment model that they've just enacted. And thankfully right before the virus, because actually it's helped the nursing homes. But before it was the RUGs, and RUGs was basically the the reimbursement was driven by physical therapy, and so that's changed. And of course, the homes needing to take a higher acuity patient to be able to get that higher reimbursement necessitates having people that can care for that patient. So
but I think the level of care is the question mark there, because you can bring a ventilator patient into your nursing home because it pays you a lot more money, but most nurses can't care for it. Legally they can, but they have no idea. They get such a small amount of training in mechanical ventilation.
Yeah.
It's almost a joke. And if people actually knew that, they'd be scared to not have a therapist there.
Right.
Especially when there's no doctors. Like in a hospital, you've got a doctor around all the time. You don't have that. You're lucky if you get a doctor there once a week.
Yeah.
You're basically relying on nurses and nurses aides. Nurses aides have no training in mechanical ventilation. And then the nurses, it all depends. There are some nurses that are really good, but not all of them. So now you've got this great reimbursement coming in, but your patient's at a higher risk for developing all kinds of things, from ventilator-associated pneumonias to, go down the list, airway problems, pneumonia.
Yeah, certainly having now a good amount of the nursing facilities have nurse practitioners there kind of all the time, which is a big help. And then, even going back to that COPD patient that's huffing and puffing and says, I can't go to PT today. Well, that now, if they do that 3 times over 14 days, now they're out of there on day 18 instead of day 14.
Yep.
And so there's a device. In fact, we had the rep on our last podcast, this NIOV, the non-invasive open ventilation, that little handheld vent basically hooked up to an E-cylinder that gives a volume and a rate as they're doing their ADLs and they're walking up the, steps and whatnot and getting their respiratory muscles tuned up and their other muscles tuned up. And so the crazy part about that is so many nursing facilities don't even know what high flow is. Less what NIOV is. And so when you introduce those devices, it's just like, me, like I'm the worst handyman ever. I hate it. I hate a leak. I hate a plumb situation or electric or whatever. But if I learned that stuff and then I had these tools to do those activities, well, truth is I still wouldn't do it because I hate doing that stuff. So I don't know where I'm going with that. Denise, where am I going with that, hon?
I never know where you're going, so it's a struggle.
One of the biggest things that I've kind of worked for 5-10 years now is, it's the most overused therapy in hospitals. You know what that is?
Incentive spirometry.
That's it. Incentive
Nailed
spirometry.
it.
And you've seen it everywhere, right?
Yep. You
know what the research says about incentive spirometry? And not just a little bit of research, all the research. It doesn't work.
Mm-hmm.
We have a clinical practice guideline, that's what you want for anything, right? In any healthcare, you want a clinical practice guideline. If you look at the clinical practice guideline, you know what the first thing it says? Doesn't work. And yet then we have this whole practice guideline about how you should use it. But it says the research, and we were all trained the same way. It doesn't matter what age you were trained at. We think any kind of heart or abdominal surgery, right? That's when we really need it. The research is the strongest that it doesn't work. Go in any home, any nursing home, any subacute, any hospital, and you're going to see millions of them. And we keep using it. And I see nurses all the time. Make sure you use your incentive spirometry. And I sit there and I go, why?
And then
the research says if you tell them to do nothing, tell them to take deep breaths on their own, or give an incentive, their outcomes are exactly the same. Yet it's given out like candy, and it's insanity. So we continue to do that. Where are there other devices that we actually know do work and there's good research for, and we don't push them as hard?
Right.
And whenever I've investigated that, it's really just, it's ignorance is really
what you're talking about, like PEP and Flutter and Acapella and all that.
But even things like the NIOX and other devices that are out there that, again, using a basic CPAP machine, you're using something that's more advanced. What is it? Philips, the V60. It's a heck of a nice, BiPAP machine. Now it's an ICU BiPAP machine, but they have home versions of it that are almost as good, and you need to know, does every patient need that? No. Some can use the basic vent. Not every patient needs an ICU vent at home. they could get away with literally a machine that just pushes air in and out because they're paralyzed or something, and they don't need all the advanced. But that's where the knowing what the technology is and knowing what the evidence shows for its benefits, I think that's where we really come into play.
Yeah, no, that's really important. I think, just talking about the future of respiratory care and respiratory therapists. I mean, how many years have you taught the program over there at, what is it, Gwinnett?
Yeah, like Gwinnett, I've been there 15 years, 16 years.
Yeah.
Maybe 17 years now. I forget. I'm getting old.
Yeah.
These numbers all run together.
So we do have a lot of respiratory therapists that tune in, and we have DONs and administrators and whatnot that listen to our podcast. Basically, we're right up there in the top 1% of all podcasts, like Joe Rogan, Oprah, us. We're
You're number 3. Yeah.
We're right there. So anyway, but point is, like, just being able, I can't think of anybody that I know, which that's not that big of a statement.
It's like 3 friends.
That if you're listening from the horse's mouth, that respiratory care is going to change significantly in the next few years, and certainly after the virus, when everybody hopefully this thing goes away. People are going to have to cut costs, certainly in hospitals. And
I agree with you. There's a big reckoning that's coming.
Yeah. And differentiating yourself is really important, and adding your value and looking for opportunities to add your value and take care of the patient. And then also have a similar goal, right? Like the respiratory department in a hospital should have a sign up that says, get patients out well and quick. And
it's not just faster, but better and faster. You can't just shove them out the door. I mean,
sure,
because they're going to come back in again.
Right.
So we need to use all of our tools. And there are some hospitals out there across the country that I've heard of that are really, and even, nursing homes and subacute, they're really taking a different approach. They realize if a patient leaves the hospital, they may not be able to afford the meds they need. Right. And so they're actually giving them a 30-day supply of medications.
Yeah, we have that. We have nursing homes that are doing that too.
Yeah, and you sit there and on the surface you say, well, that's crazy. It's not so crazy when you start looking at it, but you have to be smart enough to look ahead. There are too many places, and again, we'll take it back to the respiratory world. How many places have the two of you worked where there was, one nebulizer, one brand, and it was the 50-cent nebulizer. I call it whatever you will, but we all know what it looks like. It's blue. It's got the little, and that's it. Right. And then we have the Aerogens of the world, and we have the Aero Eclipses of the world, which are high-end nebulizers that are way more effective. And so I always have students say, well, why does everybody use this cheap 50-cent nebulizer when we know it doesn't even give more than half the medication, just gets blown out into the air or gets stuck in the machine or whatever? And I say, well, because half the treatments that we give are useless. So that's what I tell them is I say, look, when you go down, you evaluate a patient in the ER, if you happen to be at a hospital that has high-end equipment and low-end equipment, if you walk in, the patient has CHF. We all know that doesn't get treated with albuterol, yet it gets an order for it. Use the 50-cent nebulizer. But if you have somebody coming in with asthma, use the $5 Aerogen, device, or the Aero Eclipse device that's going to get more of the medication to the patient, because then maybe they don't stay and they go home. And you just save the hospital a lot of money because they just left 2 days ago. Yeah. What is that saying? That old saying, penny rich, dollar foolish. I think that's what it is. I think administrators are that way all the time. They're looking so short-sighted. They're not looking at the big picture.
Right. Yeah.
And I think that's true in hospitals, subacute, nursing homes. Go down the list. The ones that are really looking at it and saying, what's the smart way to do it? Not what's the quick fix. They're the ones that are going to survive, especially given what you said is the pandemic has really magnified everything.
I think there's certainly I can speak for the nursing home world in our experience. The nursing homes that are out there being proactive about trying to stop readmissions and wanting to take a higher acuity patient, many of them are doing it in the right way and realizing that they have to get skilled care in there. And even if let's say you don't have a respiratory therapist in your building, which obviously we recommend, but you should have a nurse or a respiratory nurse or somebody and a group of people that understand these high-tech devices and know how to utilize them. Again, in a best case scenario, having an RT or at least having a respiratory therapist available 24 hours a day is really important.
Absolutely.
And so, yeah, so I think
of all the bad COVID things that have happened, one of the biggest things that I think is a good thing is that it's really raised, and people know what a respiratory therapist is, or at least they think they know what a respiratory therapist is. But the piece that they're only seeing right now, and it's a good thing because we're getting exposure. It took a pandemic for people to know what a respiratory therapist is, right?
Yeah.
But they're only seeing the ventilator side of it. They're not seeing all the other stuff that we do before and after. We just had a webinar last Saturday, and I had a therapist from one of the local hospitals speaking, and she is a COPD educator at her facility, and she was fantastic. And the passion that came from her, but the stuff that she was talking about is, going to the bedside and figuring out how am I going to get this COPD patient to listen to me? Because a lot of them are like, I've had this for 50 years. I know what I'm doing. And she said, okay. And, she gets them to do a treatment, and then she realizes they have no idea how to do their inhaler. And she starts saying, well, did you know if you do it this way, and if she can get that one piece in, then she can get in the door. And they start to realize, maybe I don't know what I'm talking about.
Right.
And then she can really open up that floodgate of all the different things about, whether it's pulmonary rehab or the physical stuff or eating correctly, all these other things. But that's an art.
Yeah. Patient education is huge, and getting those people to listen is huge. And that's a big part of it, And
if, any facility, nursing home or hospital, if they think that nurses are doing that, they don't have time to do that. They're lucky they have time to, get to the bathroom once during the shift, because they're running and they have so many patients and so much to do. That's more of the acute care. They're not worrying about getting a patient. And I can tell you that as a patient myself. I mean, I've been in the hospital twice in the last 3 years. And fortunately for me, I didn't need a lot of nursing care, but one of my discharges, I'll never forget, because the nurse came in and she could care less. She had a bad day. You could just see it. And gave me instructions that completely were inappropriate. And it actually ended up costing me, 2 weeks of time after I got home getting to the appropriate thing. Basically, I was told to see a neurologist. All right. What I needed to see was a neurosurgeon. That's a little different. A neurologist and neurosurgeon are two different things.
Yeah.
But that's what I was told. And I'm sitting there thinking, well, here's somebody who's pretty educated and had a lot of experience in medicine. Imagine what the people who don't know any of this stuff, what they're going through. And they would have no idea.
Sure.
So.
Well, Denise, do you have any comments here on the podcast that you would like to share?
About what we're talking about, or about you?
Just in general, if you.
Well, I like the ones about him. They're more fun.
Yeah. Go ahead. Go ahead. I dare you.
Oh, you do?
Yeah. No.
What are you going to give me for Christmas? Are you going to give me that tiki boat with the?
I just gave you a shot glass.
He did bring me a shot. He lets me drink Tito's at the office.
Yeah. I just try to stay out of her way and stay in my office.
I think that would be wise.
Yeah.
Yeah, and I try to stay drunk. So.
No, that's great.
Well.
No, that's fine. Well, Mr. Tom.
Tito's behind every good therapist.
Great. So, Mr. Tom, if people want to find out more about you or learn more about what you're doing at the Pennsylvania Society for Respiratory Care, how would they be able to get in touch with you? LinkedIn or email? Or?
I'm on LinkedIn, although I'm not on there much because I'm so busy, and you get so many things in LinkedIn. Email is probably the best.
Okay.
And you can go to our website. It's psrc.net. And that would be not just for respiratory therapists, but, it gives you kind of an idea if you're an administrator or you're somebody interested in what is respiratory. I had somebody contact me the other day who heard something and had a question about the COVID crisis and heard it and actually went to our website and sent me an email from our, about us link. Yeah. And it was a great question. And she was just trying to find someone that would give her a straight answer. Oh. But our website's psrc.net. And then my contact information's on there, but it's executive director at psrc.net.
Awesome. Are you promoting us on the PSRC, Tom?
I don't know. Am I, Eric?
I don't know.
You should be.
Yeah, we're always looking to hire, and I know you've referred us people before, so I appreciate that.
Yeah, you've got some.
We're always looking for good people. That's the thing. We've had plenty of knuckleheads, but actually we haven't had that many knuckleheads.
There's been a couple.
This is true.
There's been a couple.
The difficult thing, it's funny. It's no different for any other hospital or any other places. You interview somebody and you think you know them, and then you really find out what they're like. And then it's an art form in itself, interviewing and trying to get the real answers from somebody. And I've watched people over the years do it. And some people are really good at identifying it, and some people stink at it.
Yeah.
You got Denise, so you must have been drunk that day. But besides that, normally you're not too clear headed. But that day you obviously picked a good one.
It was a win. Yep. Yeah. So as far as what we're trying to do, having this conversation is we're trying to identify an issue here that their respiratory care is changing, and like to be honest and say everybody has to adapt or they're going to get left behind, And
I've been saying that for years, and I think what's going to happen is what we talked about earlier. You're going to have two different types of therapists. You're going to have the hospital care is going to move almost completely to intensive care. And how many ICUs do you have in a hospital, right? And then you might have one or two therapists that are going to run around the hospital putting out little fires, but you're not going to have all the floor care. And right now, Thomas Jefferson University Hospital, they haven't had floor care in, I can't remember how long.
Wow.
And now they're a big place and you think, well, they can get away with it, but that's the model I think more places are going to follow.
Sure.
And for better or worse, and you can make an argument that you should have a therapist on every floor, but it's not just doing treatments. It's doing effective treatments and evaluation. And if therapists don't get that idea, then you're right. They're going to get left behind because it's going to be ICU care and it's going to be home care / subacute / outside the hospital care. And that's a whole different skill set. I mean, you know that better than anyone. I mean, you worked in hospital and out now, and you see the difference. And it's if you can't talk to patients, you don't like talking with patients, you went to the wrong field.
There's a job for you. It involves Mr. Bezos and lots of boxes, and there's a warehouse. So you're welcome to go over there. So
and remember, and you guys know this again, that where healthcare is being delivered is growing. It's not growing in hospitals. It's growing everywhere else. Yeah. So if you're a therapist, you should be thinking about that, especially if you're a young therapist.
Yeah.
You should be thinking about what am I going to do? Yeah, I love ICU care too. Hey, I still do it, and I love it. It's really my thing, but I did pulmonary function testing for years.
Mm-hmm.
I love that too. And that's literally sitting with a patient for 45 minutes talking to them. And home care is the same thing. There's a special technique. You really have to know what you're doing and be comfortable with yourself and be comfortable talking with people. They're all skill sets that people have to work on.
Well, I would like to say, I think everybody did a great job on the podcast today, but I got to tell you, Tom, I think I probably did the best job as I really evaluate.
Denise and I probably did the best. She said
that's a subjective statement. That's a subjective statement, Mr. Pitt. So, but I do appreciate you coming on, and I'm glad to hear that you're feeling better. And I guarantee you one thing, that I will continue to harass you for things like this. And then at some point, once the world stops having viruses, then we can go have a drink or something.
Yeah, notice how he said that, Denise. After we have viruses, not the virus, but viruses in general. So
all of them are wiped out.
All the virus. So
basically, he never wants to have a drink with you.
Exactly.
That's not nice, and that's not true. So
I'll drink for you.
There you go. Well, I appreciate you coming on the Hey, Can Someone Please Call Respiratory podcast. What do you think of that name? Not
Nailed
bad.
it. Huh? I'm really proud of you.
Unique, yes.
I mean, it's kind of our thing. Hey, can somebody call respiratory? And it's usually not a please. But actually, when you see it in the theme music, it's my Aunt Carol. She's 80 years old, and I needed somebody a tad bit older that sounded like a nurse, and she absolutely nailed it. So when you hear somebody, hey, can somebody please call respiratory, hon? That's my Aunt Carol, and she did a great job. I think she did the best job on the podcast today. So appreciate you, Tom. Thank you so much for coming on the podcast, and we will now have Joel cue the music. Swipe up. You don't swipe up because there's no swipe up function, but I really like to say swipe up, and it looks really professional. So swipe up if you want to get this podcast in your face, and fantastic. So everybody did a great job, and way to go, everybody.